This
Hi, this
conference will now be recorded.
Morning, everyone, and welcome to the CureGN Study Coordinator Town Hall. So just a few housekeeping items. This town hall is being recorded, so if you're not speaking, please mute your phone. The recording will be available on the study website. And if you want to ask a question and don't want to speak, you can use the chat function that's on the right side of your screen. So today we're going to discuss the importance of data collection and queries, as well as the dashboard and SMS, and why we collect Social Security numbers and census tract information, as well as the CureGN2 consent project and retention QI project and report cards. And then you'll all have an opportunity to ask questions. So first up, we have Dr. Howard Trackman, who will be presenting on the importance of data collection and queries.
Thanks so much. Thanks so much for the opportunity to talk to you. And I think you obviously know that your contribution to the study is indispensable. And I know all of us PIs, all the site PIs really have to thank you enormously. The two things I want to emphasize is that in renal disease, there are two principal outcomes that we measure. One is GFR, which is considered by the FDA the hard clinical outcome. In other words, people care most importantly, I guess one is mortality, obviously, and the preservation of kidney function, and that's by GFR. And the most accurate way was with measurement. These are injection of molecules that are cleared by the kidney. The one that's most widely used in, I think, both pediatrics and adults is iohexol, but this is not part of CureGN, and therefore we rely upon serum creatinine and occasionally cystatin C, and then we use formulas. The adults use CKD-EPI, and in pediatrics we use the modified Schwartz. One of the things I think that you should all be aware of is the important and really groundbreaking discussion about the role of race, whether this should be a factor that should be incorporated into GFR formulas. And again, I encourage all of you to stay tuned. There was an article in JSON that you may want to look at. It's a nice overview. It's an interim report of a panel convened by the ASN and the NCAF that outlines the issue, and I think it'll be helpful to all of you. As far as proteinuria, that's what we see in glomerular disease, and I think you should recognize that though it's not the clinically hard endpoint, which are mortality and preservation of GFR, there's increasing acceptance of proteinuria as a valid and meaningful surrogate endpoint, meaning that measurement of proteinuria is in the pathway to decline in GFR, and documenting changes can predict these GFR outcomes. We can measure total protein in the urine or albumin. In CureGN, we are measuring total protein. We can either do it in a 24-hour urine or a spot protein. The adults seem to be wedded to a 24-hour urine. I'm a pediatrician, so obviously I find it much more convenient to ask children to provide a spot urine, and we put our reliance on the first morning specimen, which again is an option in CureGN. Next slide. This is, again, just that in all studies, there can be changes in the course of GFR. There can be acute changes in response to the administration of medications. The one that we know the best about are angiotensin converting enzyme inhibitors, lisinopril, ramipril, or the angiotensin receptor blockers like losartan. And those of you that are involved in the adult side, the SGLT2 inhibitors are also in this category, causing acute changes. The one that we as nephrologists, pediatric and adult, are engaged in looking at the chronic change over time, whether the things that we're doing for patients are improving their long-term outcome by delaying or reducing their slope of GFR decline. Next slide. And this is what we see. So the reason why Scott and I have included this slide is that there are ways, as coordinators, you should be aware how the biostatisticians, the people at the data coordinating center, are analyzing the data. One is as a categorical variable. In other words, you have a GFR less than 60, and that's CKD stage 3, and you can assess interventions by whether there is incident CKD. It's a yes or no variable. Alternatively, you can look at GFR as a continuous variable, as the rate of decline. And both of them are important, and they're often, they'll be influence the design of clinical trials, and therefore it's important in a certain way. The categorical thing is categorical assessment, sort of easy. It's above or below a line, and you might think that the accuracy is more important in continuous variables, but again, it's really important that we get meaningful data, that we can analyze it according to either of these outcomes. Next slide. The same thing applies for proteinuria. And we can either look at it as a categorical variable, in other words, whether you can lower the patient's proteinuria below a certain defined threshold. So in other words, we all know that if we can make proteinuria go away, completely normalized, that usually indicates a very favorable outcome. What about less than perfect? And this is data that's come out of Neptune that shows that this new partial remission endpoint, lowering the proteinuria by 40% to a value less than 1.5, has prognostic implications that are closer to a complete remission versus a no response at all. And this is important. Hopefully this can be validated in CureGN, which is a much larger cohort, a little bit more of a heterogeneous population. So this would be analogous to the categorical assessment of GFR. Incident CKD versus not, GFR less than 60. Alternatively, people at Neptune, next slide, I'm sorry. We can also look at proteinuria as a continuous variable. So in other words, what if you have terrible proteinuria and you lower terrible by 15%, it's 15% less terrible, or 40% less terrible, all the way down to a complete remission. And this is data, again, from Neptune showing that if you evaluate proteinuria continuously, this is associated with a parallel benefit in terms of GFR protection. So again, it highlights the creative ways that the data, the information that you're collecting in the patients in CureGN can be utilized in the most thoughtful way that we can document the natural history of patients and the effect of the things that doctors are doing routinely or in clinical trials. And again, how can you collect protein? You can either assess it by its dipstick, or you can do it quantitatively. And again, these are pediatric issues, clean catch versus a bag, 24-hour urine collections. I don't know if any of you have done that. I've done it once, and it was a total pain, I must confess. But an early morning and spot urines can either be obtained in the clinic or when the patient wakes up, first thing they do in the morning. Next slide. And again, the other thing I wanted to emphasize, I added, is that you should be aware. I know it's an enormous amount of work, and the coordinators work enormously hard collecting the data on patient-reported outcomes, but I can highlight how important this is. The FDA recognizes how important this is as a valid endpoint in clinical trials. So the work that you're doing, asking the adults, the pediatric patients, the adolescents, or the parents to fill it in for responding for their children, it really hopefully will be used. I know there have been manuscripts that have described these outcomes in the patients enrolled in CureGN, and they will be important long-term. Next slide. And then this is a funny slide that Scott had, and I'm just gonna make no comment on this. You can laugh at this on your own. Next slide. And and this is the importance of categorizing the patients for relapse or remission. These are the things that we see with nephrotic syndrome: steroid sensitive patients where the proteinuria goes away, steroid dependent with relapses quickly or while they're on steroids, frequently relapsing, meaning they relapse more than twice in 6 months or 4 times in a year, and then the most dreaded category, steroid resistant, where there's no response at all. I think that's the next slide. I think that's it. Again, I just want to thank you all. You are absolutely vital to the conduct of the study, and hopefully you should reach out to any of the staff personnel, me or Scott or any of the personnel, so you understand the meaningfulness of what you're doing so that you do it as best as you can. Thanks to all of you.
Thank you, Dr. Trackman. Does anyone have any questions? Then we will go ahead and move on to the next subject. So the dashboard and SMS, and we have John Pate from U of M, who's going to present for us.
Yes, hi everybody. I'm John Pate. As you can see, I'm the director of the Center for Managing Chronic Disease here at the University of Michigan. And we've had the pleasure of working with CureGN and prior to that Neptune team to develop ways to collect data remotely from patients between face-to-face encounters with their clinical team. So we've done some really innovative work as part of Cure and Neptune. So I'd like to tell you about that and maybe even put a bug in your ear about some ways that we can make this process even more effective, as we move forward. First, I'd like to say a few things in general about this field of collecting data remotely or intervening with patients remotely. This is the field we're now calling mobile health. It's of course more important than ever in the area of COVID, but it's always been really important, and it's important for a couple of different reasons. The first reason is of course that everybody's got a phone. That's of course, then it's a little bit of hyperbole. Not everyone has a phone, but what we find is that, next slide, please. Even in some of the most low-income, communities and countries, phones are just kind of part of daily life all around the world. So what you see here, that top line is data from the United Nations on the penetration or the number of people that have a phone in the population in developed countries like some of the countries that are participating in Cure. And we're now to the point where there's actually more phones than people in countries like the United States or Italy or Canada, et cetera. That lower line shows you that's what the penetration is or the prevalence of having a cell phone, even in low-income countries. I work a lot in Central America, or in poor countries of South America and Africa, and phones are really incredibly common around the world. So for the first time in the history of the world, we have a device that we can communicate with patients about, in this case, their proteinuria, their symptoms that they might be having due to their kidney disease, their patient-reported outcomes, et cetera. So that's a really exciting opportunity. Next slide. The fact that everyone has a phone isn't quite enough as a reason. I mean, people have a lot of things that we don't necessarily see as part of their management for their chronic disease. Next slide, please. But the other harsh reality is that we've just heard about how important it is to get updated data about patients' proteinuria in this case, or their edema, other key outcomes that we're trying to track. But the fact is that just doesn't happen well during face-to-face clinical encounters. Click, please. These are data from one of the investigators of Neptune. I think Dr. Wang is still very involved in Cure, I believe. And it's data from a safety net healthcare system here in Atlanta, Georgia, of patients with childhood kidney disease. And you can see that it's no surprise, but not good news, that almost a third of the patients were missing at least 20% of their visits, some much more than that. 45% weren't adherent to their dipstick monitoring, and 43% were poorly adherent to any kind of medication regimen. So, dealing with these issues and communicating with patients and identifying problems and doing self-management support during face-to-face visits, it just doesn't happen. So, the idea that we can reach out to patients between visits, as we're starting to do now in Cure, is very exciting. Next slide, please. And we do have evidence. I won't go into it in great detail. It usually goes much far beyond the area of kidney disease. Actually, some of the most important work on the use of cell phones in kidney disease has been done by Cure investigators, Neptune investigators. It's what we're doing as part of this collaboration. But suffice it to say that, next click, please. It is true that, hi, can you forward? Thanks. And then might as well go next. there's a very, very broad evidence base now that we can go back to one slide, that we can improve a variety of self-management behaviors by communicating with patients through text messaging or other mobile health technology. So if you're familiar with it, this is a result of a meta-analysis that to me was kind of definitive. These are all randomized trials where they texted patients with a variety of chronic diseases, not only in the United States, but in low-income countries of Africa, with all kinds of situations and conditions. And they were trying to help them take their medications as prescribed. And what they found was that consistently across studies, text message reminders and other sorts of behavior change support by text increased medication adherence about 15%. So if someone was taking like 50% of their pills as prescribed, they'd be taking 65%. So a really meaningful increase by something that's pretty accessible around the world and not necessarily very high cost. So these sorts of studies have led me to really see some of these areas as kind of decided, like they're almost not research questions anymore. We just should be doing it to help our patients, in this case with kidney disease. Next, please. In addition to things like medication adherence, might as well click again, please. Lifestyle behaviors, this is just one very definitive trial of a texting program that was done in the UK with 5,000 people who trying to quit smoking. Click again, thanks. And what they found is that they actually doubled smoking cessation rates through a series of texting. So some of the behavior problems that I mentioned earlier that patients with kidney disease struggle with, you can make them better. I'm quite convinced that we can help them with those behavioral issues by sending, texting, maybe having feedback to their clinical team. Next, please. Now, getting more specifically to the area that's really focused on CURE and our patients in CURE. As I said, this is very exciting to me because I think we've done some of the most important work in this specific area as part of this series of studies, specifically in Neptune. So this was a study that, again, it was just really important. It was a great study. And I'm really hoping that we do a lot more of these sorts of studies with the data that we're currently collecting as part of CureGN. So, we just heard about how important it is to have data on proteinuria and edema and other outcomes from patients so we can track how they're doing and so we can titrate their medications and really serve them the way they deserve to be served. So one question though is, can patients report accurately about things like proteinuria and edema in a way that clinicians can take that information seriously? This was a study that was based on Neptune, and in Neptune for over the course of a year, patients were receiving texts very similar to the text that they're going to be getting or are getting now as part of CURE. And they were asked questions about their proteinuria, about their edema, about their medication adherence, etc. And so they were reporting on some of those same outcomes that clinicians try to track when they come in for face-to-face visits. And these investigators did a really, really important and interesting thing. They found cases in which the patient reported their level of proteinuria at home via text message, and they happened to have an in-person visit in the clinic, and that proteinuria level was collected in the clinic. So they were able to basically compare and see how accurate their home report was compared to what was being collected in clinic. Next slide, please. Next slide. Thanks. So, you can see here in the table, what you'd hope to see is that if patients were reporting accurately with their texting, and that it was, you'd basically get the same result when they reported it at home as when they came into the clinic. Make a click, please. And so things would, you'd hope things line up around that diagonal. And so they had, about 127 cases of this instance where patients were home reporting and then went into the clinic. And sure enough, 77% of the time, the agreement was exactly the same. And this is measured, by something called a kappa statistic. And kappa statistic of 0.76 means that, over and above chance, the agreement between home testing or home reporting and in-clinic reporting was really, really excellent. Patients could, of course, to be fair, be off by 1 degree because things could change between the time that they were home and they went into the clinic. So make a click, please. And so when you include things that are off by 1 degree, and call those as quote unquote almost the same, the agreement was about 94%. So this is an excellent reporting. So that was a great finding from Neptune, that we can in fact collect these data that clinicians can take seriously. So that, a really important kind of secondary finding of the Neptune study. Next slide, please. Similarly, patients again were reporting, at home and about edema, levels of edema, and then they went in and they had their swelling evaluated by the clinical team. And guess what? Once again, that should be exact agreement, was 96%, with the kappa statistics at 0.92, meaning that patients weren't able to evaluate their level of swelling and report that to the clinic between face-to-face encounters. So we do have a sense that patients can report by texting very, very accurately, and that has a variety of benefits. Next slide, please. This is another graph from that same paper, because if you're able to take those home reports of proteinuria seriously, you're able to kind of identify what proportion of patients are in the nephrotic range over the course of the time of participation in the study. And as you might expect, because they were reporting much more frequently at home, the number of patients, or the proportion of patients that we identified as being in the nephrotic range, was significantly higher when we evaluated that by SMS or text messaging than if we had to wait for them to come into those clinic visits, which, as we've seen, they aren't always able to make those clinic visits. So, we're able to identify more cases of problems by texting, and it was really important to be able to show that as part of the Neptune study. Similarly, if we're looking at time to remission of proteinuria, of a kind of a nephrotic episode for the patient, if they're reporting more frequently, we should be able to identify that they're in remission much more quickly, much more accurately. So next slide, please. And sure enough, that's exactly what we found, that if we waited for or only depended on data that patients had available from an in-person clinic visit, we estimated that there was about 50 days until time to remission from an episode of proteinuria. But if we use the text messaging data, it was less than half that. It was only 22 days, because again, they were reporting for much of their time every day, and then after that, every week, as part of the Neptune study. So some really important findings, showing the value of this between visit monitoring for these patients, that we were only able to have these findings because of the use of texting and Neptune. And like I said, now we're building on that in the CURE study. Next slide, please. So in the CURE study, we've done a variety of things to make our texting program for patients and participants even better. Patients are able to log in. We have a patient-facing portal, so they can log in. They can contact the clinical team or the CURE team. They can ask questions. Next slide, please. They can, this is really great, not just from texting data, but some of this is texting data. They can track their own progress. They can monitor how they're doing, and when they're in the red zone on things like blood pressure or proteinuria, and kind of see how they're doing over time. There's newsletters, there's ways to keep people engaged through the patient portal that is very useful. I think I sort of mentioned maybe briefly already, but if patients do report that they're having a problem with edema, if they're having a problem with their texting, automatically there's an alert that goes back to the CURE team so that they can act on those, and so that they can support patients. So while this is primarily being used as a tracking mechanism, to track patients, clinical progress, as a monitoring tool, it has some real clinical benefit to patients as part of CURE. So next slide, please. So a couple of things, in Cure overall now, we've implemented the texting program in all of the countries and all of the sites. It's available now throughout the Cure study. We've offered the texting program to about 1,300 possible participants. And the majority of those participants say, yes, sign me up, I want to do that. It's an optional thing, but when patients are offered, most of them say they want to participate in the texting. We've sent, I'm looking at the exact number of data, I think we've, as part of patients, we started really the texting communication with Cure patients just at the end of this last year. So it's only been up and running really for, about 4 months now, but we've sent about over 2,000, texts to patients. The response rate, the reporting rate is, for reasons that I don't frankly totally understand, a little lower than it was in the Neptune study. So patients are responding to about 40% of the texts that we're sending. So they've sent back, 700-800, texting responses about things like their proteinuria or their swelling or, their medication adherence, et cetera. So, I would say, for all of you as coordinators, if there was a couple things that we'd like to do as we move forward to make this even more impactful, even more beneficial to patients, even more important scientifically, it would be two things. One, make sure that we're really, really conveying to potential participants that, while the texting program is optional, most people find value of it. It does populate that dashboard that you saw. They can track their own progress. That updated data does come back to the team. So it's certainly easy to do. The texts that come to patients, I think they're once a month text, is very, very low impact on the patient side. All the data are being maintained in a very secure, kind of state-of-the-art, industry standard platform of data security that we use here in the US in the VA healthcare system and the University of Michigan healthcare system. So there's no data security privacy issue concerns related to the texting program. So I would, say that we want to continue to make this program available and let participants know that it's available. It might be beneficial to them, but it's certainly, in addition to that, has some real scientific value. So we can answer more of the questions, like the questions that I just showed you. So we want to get patients to enroll in the program. And then, as I mentioned, if they're not being responsive to the text, an alert goes back to the Cure team. And so we want to understand better why patients aren't responding to their text message and, help them troubleshoot if they're having any problems. Some people might forget, what's this text about, when it comes, 1 month later after they enrolled in the program. So, be sure to kind of let them know that that's what those texts are, that's why and how they're being used, and, to kind of get those engagement rates up even better than they are now. Next slide, please. I think that's it. So yeah, if anyone has any questions, I'm happy to answer those now, or feel free to send me an email. Thanks.
Thank you so very much. Does anyone have any questions for John? Okay. Again, if you do, you can either email the project management team for CureGN and we can forward them on to him, or you can use his email address that's here. Once it's posted online, you can also grab that information. Thank you again, Dr. Fate. We appreciate your presentation this morning.
Great, it's a pleasure.
So we're going to go on to the Social Security number and census tract information. So why do we collect this information? So the Social Security numbers link the data to external data sources, such as the Centers for Medicaid and Medicare Services, the end-stage kidney disease data, as well as the National Death Index. So that way, if you have someone who you just haven't been able to get in contact with, you can do the searches to see if they have had one of these end stages. And then the census tract information just provides residential census tract location at enrollment. And it's definitely useful in analysis. It helps to identify and understand patterns and characteristics within a stable set of geographic units. So that's why these two pieces of information are very important. So let's go ahead and talk about the CURE2 consent process. So it has changed a little bit to make it a little bit easier for you. And this is just a diagram of the workflow. So what happens is now you go into the screening form for both new CureGN 2 participants as well as those that are coming over from CureGN 1. And then once you're into the screening form, you'll see that there is a page for CureGN 2 consent, as well as you can view the CureGN 1 consent. If it's a new participant, when you go to the CureGN 2 consent page, it's going to ask you if they were previously consented in CureGN 1. So you would put no, and then you would have E3 through E8 to answer. Okay. Now, if it is a returning subject who you need to re-consent, when you put yes, it'll then give you questions 9 through 14 to answer. Okay. And then the last section is for the consent confirmation, which whoever is confirming that the consent information is entered correctly into link at the site would put their name in here, and then the PCC lead coordinator who confirms that it was entered correctly will put their name in there. So this is just really important that we make sure that the consent information is correct, because we don't want to be, one, having anyone in the study who did not want to be in the study, and two, when it comes to the biosample collection and DNA collection, we want to make sure that we have the correct information. Any questions on the consent workflow or the Social Security numbers and census tract information? So now we'll talk a little bit about the Retention QI project, and I will hand this over to Suzanne Bento.
Hi, everybody. Thanks for joining. I just want to briefly touch on the Retention QI project and see how everybody's making out with their interventions at their site. Has everybody implemented the interventions at their site that they chose to improve retention? On the last call, it's pretty much radio silence. So we're wondering if if you have initiated these interventions, have they had any impact on retention at your site? Somebody mentioned on our last call that they are seeing, an improvement in that at risk for loss to follow-up group, which is the patients who have missed two visits and are at risk for being lost to follow-up. So that's an important group to keep in and capture. And the other thing, we're wondering if anybody's had any barriers to these. Maybe you chose intervention and now you're unable to implement it, and we're just wondering if anyone has any feedback, comments, or issues they've encountered with the project. Please feel free to reach out to your lead coordinators if you don't remember your interventions, or if you are having issues with them and you want to change things around, or any other comments in general related to the project.
Okay, I think somebody had a comment.
Yes, this is Krishanda Holmes from Levine Children's Health Hospital. I have implemented some of the interventions that I've identified on the report when I've submitted. I am a new coordinator that was assigned this study right before the pandemic, so I'm not really aware of the issues of what was going on prior to the study being assigned to me, but I really haven't had any issues as far as even though I implemented the interventions. Most of the current active participants that are currently active in the study, I am able to see them or get in touch with them as far as in-person visits as well as remote visits.
Okay, that's terrific. And have you had any problems with the interventions that you've implemented? Everything's been going smoothly?
No, I haven't had any problems at all.
Terrific.
It's almost time for some of the visit windows to open again, so I will ask the patients as well as their parents, how they like the interventions that were implemented at the site.
Okay, very good. Thank you so much.
Great. Okay. Did anyone else have anything they wanted to add or questions? Well, thank you, Suzanne.
Thank you.
So now we can review the CureGN 2 report cards. So they have changed a bit from the CureGN 1 report cards, and the ones that came out in December were on the new form, but some of the data wasn't populated, and that was just because of the transfer from CureGN 1 to CureGN 2. We wanted to make sure everything made sense and that it lined up correctly. So, and with the pandemic and so many things missing because of not having the in-person visits. So when the new report cards come out, which I am hoping by the end of this month, which is soon, they'll be ready. If not, it'll be the beginning of next month. But we will get these out to you. So a couple of things I want to point out about the new report card is, one, we do still have the cumulative from the beginning of the study, which will be the very last column. But now what we're looking at, these first two columns, is just the contemporary data, which is, so it's only data from January 1st of 2020 through the current period. So this next report card then should be around from January of 2020 till about the beginning of March of 2020, and it'll have the exact date. And then the previous contemporary would be from the previous quarter. So whatever was in this column to begin with, or on the first report card, will be now in the previous contemporary. So it'll be through the last quarter. So it will be a little bit easier for you to see like how you're doing. So a lot of coordinators who have taken over may not know, like, okay, so this is what we're doing overall, but we want to know, like, how is what I'm doing varying. So this will give you a better idea of what you're currently doing. And then we do have the arrows. The green means that it's a positive change. The red is a negative change, as well as the blue that is it stayed the same. So you'll notice that some of these have an arrow going, green has an arrow going up, and some have an arrow going down. So if those going down, it just means if the number goes down, that's a good thing. So withdrawn participants, if that goes down, great. As well as participants at high risk for loss to follow-up. If that goes down, that is a positive. As well as the loss to follow-up. So this is a negative that looks going up, and it's just because we have more people in this loss to follow-up category now. So that's why sometimes the arrows don't quite match with the other arrows. So you just have to look at what the metric is. But just know that green means it's a definite positive. Okay. And then we still have the red zone metrics. And those are the ones that are going to have colors. So we have the completed visits, the annual in-person visits, as well as the CRF completed. And then we have annual blood, annual urine, and then DNA ever collected. Okay. And so green means you're performing at expected. It's more than 90%. And if it's less than 50%, it's going to be in the red zone. It's 70%. It's in the red zone. And then if it's between the 70 and 90, then it'll be in the yellow zone. Okay. Another thing that's changed on the report cards is the PROs. So before we used to have PROs and then proxy PROs as separate entries. Now they've been combined into one metric. So you just have the overall PROs completed. So that includes the ones that the participants complete as well as the proxy ones. Okay. And then we also still will continue to have the pathology. And even if it's not in the red zone, they'll still put the arrows in just so you can have at a quick glance see how everything is going. And then we have the DPR on here. Once that gets started, I know they're working very hard at getting that set up. And so once that gets started again, we'll let you know. And then, of course, the data quality, which is the queries, will also be on here. Okay. Any questions about the new CureGN 2 report card? So now it's your turn. Does anybody have any questions, comments, feedback that you would like to share? This is open up to you. Everyone's so quiet this morning. And that's okay. If you're not comfortable, if you don't want to speak up at this time, that's fine. Just know that if you have any questions that come up later that you want to email, please do. You always want to email the CureGN-project management at arborresearch.org, and we will make sure that the appropriate person responds to you. If you have an issue with the GN link, still again, you can email the project management team, but also make sure that you CC CureGN help at arborresearch.org. Okay, that way a ticket automatically gets open for you. And if you don't, that's fine. We'll still open a ticket for you. But you also want to CC your PCC lead coordinator. So anytime you email the DCC at the project management email address, always copy your PCC lead coordinator so that they are aware of what's happening, okay? Because sometimes we'll reach out to them to help us out with your questions. And always be sure to include the examples such as the study ID, which visit it is, the CRF. If you have a screenshot, that really helps with questions for link. Okay. So the next round of town halls is going to be in July. If you have any suggestions or ideas, please email them to the project management email. Because we want these to be beneficial to you, we want to be telling you the information you want to know. So definitely any suggestions on what you'd like to see, let us know. Okay, so is there any questions? Has anyone thought of any questions that they might like to ask? Okay, well, we thank you for coming and joining us today. And we look forward to having you on future town halls. And you have a wonderful day.
Thanks, Melissa.
Thanks.